Is a paid program. WFEA is not responsible and accepts no liability for any of its content. The opinions, views, and advice expressed during the show are solely those of its participants and not those of WFEA, its advertisers, or management, and should be used as such, as every individual situation is different.
It's time for On Call with Minuteman Health, bringing you an hour discussion with New Hampshire physicians and healthcare experts on topics ranging from specific medical conditions to our changing medical system. On Call with Minuteman Health, helping you understand healthcare. And now, here's your host, Scott Colby.
Good morning, folks, and welcome to On Call with Minuteman Health. I'm your host, Scott Colby, and happy Wednesday, rainy Wednesday to you. It's March. We finally made it. Before we start the show, just a little self-deprecation here. So as Heather knows, and she's going to roll her eyes every day before I get here, I do a workout at the Executive Health and Sports Center. And I go to get dressed, and I pull my shirt out, and I had accidentally grabbed a tuxedo shirt. So we're going fancy today, Dr. Ryzewski. We're going very fancy.
Scott, you look very dapper this morning.
Well, thank you. I appreciate you noticing. Dr. Matt Ryzewski of the Elliot Hospital is here. He is a neonatologist, and we are here to talk about the specialty of neonatology today. So, Dr. Ryzewski, once again, welcome, and thanks for joining me.
Scott, it's a pleasure to be here. Good morning.
Great. Let me introduce you to our listeners, and then we'll jump right into the topic. So, Dr. Matt Ryzewski attended medical school at the New York College of Osteopathic Medicine, completed his residency at SUNY Upstate Medical University in Syracuse. He is board certified in pediatrics and also board certified in neonatal and perinatal medicine. He is fellowship trained. He did that training at UMass Memorial Medical Center in Worcester. And once again, he works at the Elliot Hospital here in Manchester in the NICU, which stands for Neonatal Intensive Care Unit. Is that correct?
That's absolutely correct.
All right, Dr. Ryzewski. Thanks again. Why don't, before we get into the specialty of neonatology, I want to have you introduce maybe your program at the Elliot Hospital. I'm a lifelong resident of New Hampshire and have known of the Elliott's program for many, many years, and it definitely has a great reputation. And I was wondering if you could explain a little bit about the program and how you work with other programs throughout the state, and then we'll sort of step back and talk about the specialty.
Certainly. So here at the Elliot, we have a 26-bed neonatal intensive care unit, and the designation of the unit is what's called a level 3 intensive care unit. So what that means is that we take care of the sickest newborns in the region, and we take care of the entire spectrum of newborn care from babies who are extremely premature all the way to babies who are actually born after their due dates, and every baby in between. Okay. So we take care of very small, very critically ill newborns, and we also do newborn care for term infants who have some illness.
So you said that you're a level 3 NICU. How many levels are there, and where does 3 fall on that spectrum?
If you look throughout the country, Scott, there's actually 4 levels.
Okay.
Certain states have units that are, we'll start from the top.
Yep.
Certain states have units who are designated as level 4.
Okay.
And that stands for
most intense.
They also take care of the sickest babies, but but those states have a particular designation as a regional perinatal center.
Okay.
New Hampshire does not have a level 4 designation, so for our purposes in our state, level 3 is the highest designation of neonatal intensive care. Level 3 also takes care of the sickest newborns, extremely premature. Level 2 units take care of babies who are typically late preterm infants. Those are babies born somewhere between 34 to 37 weeks, and sometimes a little bit younger than that. And then level 1 units mostly take care of term newborns.
Okay. And a term, I'm going to sound like a knucklehead, Dr. Ryzewski, but it's 40 weeks, right?
Term is actually 37 weeks and above.
37 weeks and above. What's the norm then? Anything that's 37 weeks or above is the norm?
Yes. And so term babies, the definition is 37 weeks and above.
Got it. Okay, great. So Elliot is a level 3. So you're taking care of very, very sick babies. And from what I understand, you do a great job at that. The specialty of neonatology has not always been around, right? And when we talked a few weeks back, about 40 years, 45 years?
That's right. So relative to the history of medicine, which goes back centuries, neonatology is probably one of the more younger fields.
Okay.
In that it goes back typically now probably 40, 45 years to the early to mid 70s. And a lot of neonatal ICUs throughout the country began in their nascency sometime around 1972, 1975.
Mm-hmm. What was it that spawned that specialty? Was it just advancements in medical technology and understanding? Was there something else at play?
If you look back to the 1960s, there began to be an upsurge in the interest and the specialty of taking care of critically ill newborns. One of the more prominent historical facts that many people know about is actually JFK and Jacqueline Kennedy had a baby boy, Patrick, in 1963, who was born prematurely at 34 weeks gestation.
Okay.
And at the time, not much was known about babies born prematurely, and Patrick Kennedy had very significant lung disease and actually died within the first week of life.
Okay.
At Boston Children's Hospital. And that spawned almost a critical urgency and a higher level of interest in how babies transition after birth and also the risks of being born prematurely. And after that, there began a higher level of interest within the medical community and the development of specialty programs.
So, Dr. Ryzewski, 34 weeks today seems like, oh, that's fine. 34 weeks, not a problem. It's standard. But was that, and I don't mean to be crass or callous whatsoever, but was that almost a death sentence for a baby if a baby was born at 34 weeks, or could they still make it?
It certainly depended on the individual baby.
Sure.
But certainly, even babies born today at 34 weeks can have, for example, significant lung disease, or they could be totally fine after birth. But the advancements of medical therapies and medical managements of babies at 34 weeks has grown exponentially and has gotten so fine-tuned that babies at 34 weeks today have a much greater chance of surviving and thriving than they did, say, 50 or 60 years ago.
So, Dr. Ryzewski, we've got a couple minutes before break, and we're going to continue to help our listeners better understand the specialty of neonatology. But what caused you to want to pursue this specialty? You go to medical school, right? The world's your oyster. The body is your oyster, and you can choose any specialty that you want. But you went into this. And what drove you in this direction?
That's an excellent question, Scott. And really what spurred my interest was being in the delivery room.
Okay.
In the delivery room, you're a father. You've been in and around the delivery room before. It can be a very exciting place.
Sure.
And there's a little bit of an adrenaline rush when a baby is born. And also, so that's certainly part of it, and that still exists for me today, years after my training.
So you have a thrill gene.
I certainly do, and it's alive and well. Also, too, there's a very distinct transition that happens for babies when they transition from being a fetus, which is the baby growing inside of the womb, to being a newborn. And the respiratory system makes a very abrupt transition, and the circulatory system also makes a very abrupt transition. So that change, that shift in the dynamic, for me, represents a very fascinating physiologic principle. And that's where we come in, at that transition zone.
Great. Well, Dr. Ryzewski, we're actually up against break now, so we're going to cut away. And when we come back, let's talk more about the clinical conditions that you might see in a premature baby and define that a little bit better for our listeners. Folks, Dr. Matt Ryzewski, of Elliot Hospital is here to discuss the specialty of neonatology. 603-669-1370 is the number. We'll be right back.
People are finally doing something about the rising cost of their health insurance. They're switching to Minuteman Health. Minuteman Health could save you $1,000 to $5,100 a year on your premiums. Enroll at MinutemanHealth.org. Savings based on healthcare.gov comparison of the lowest cost 2016 silver plans for all carriers in 03215 for a family of 4, 2 adults age 40 and 2 children under 21, all non-smokers. Provider networks, benefits, and cost-sharing amounts vary.
St. Joseph Hospital now gives you more room to relax inside our new wide-bore MRI, used to help diagnose possible injury or illness. Patients who might find conventional closed MRIs difficult to tolerate no longer have to sacrifice comfort for the quality of their images. St. Joseph Hospital's new MRI unit will provide you with a faster, quieter, and more comfortable MRI exam without that closed-in feeling. We offer appointments 7 days a week for added convenience, and we promise to provide your exam results as quickly as possible. Top quality imaging for precision diagnosis. Expert care in a stress-free, patient-friendly environment. The latest innovations and technologies. It's just what you'd expect from St. Joseph Hospital. To learn more about our new wide-bore MRI, visit us at stjosephhospital.com. That's stjosephhospital.com.
When your diagnosis includes the word cancer, you want your care to be the best possible. At New Hampshire Oncology Hematology, their mission is to provide expert and compassionate care for adults with cancer and blood diseases. Their providers are committed to their patients and their fight. All members of their staff value honesty, teamwork, and communication with patients, their families, and all members of the care team. You and your family will always be treated with dignity and respect at New Hampshire Oncology Hematology. To learn more about their cutting-edge care close to home, visit NHOH.com.
You're listening to On Call with Minuteman Health. This show is informational and not intended to be used as a way to diagnose or treat medical conditions or to replace an appointment with your medical provider. For immediate and medical attention, consult your primary care physician, call 911, or seek care at the nearest emergency department at a local hospital. And now back to On Call with Minuteman Health.
Good morning, folks, and welcome back to On Call with Minuteman Health. I'm your host, Scott Colby. Excuse me, easy for me to say, right? In the studio with me this morning is Dr. Matt Ryzewski, neonatologist at the Elliot Hospital here in Manchester. Dr. Ryzewski, once again, thank you for joining me.
Scott, it's a pleasure.
Great. Folks, if you have any questions about premature birth or neonatology, 603-669-1370 is the number, and Dr. Ryzewski is happy to take any questions you might have. So when we went on break, Dr. Ryzewski told another story that I think really supports the specialty, and this is actually a wonderful story, and probably a story we should have told at the very beginning. But Dr. Ryzewski, I'm going to invite you to share that story with our listeners.
Certainly, Scott. So during the warm-up, we had talked about, have you ever been on an airplane when someone said, is there a doctor on the plane?
Right.
And I said, no, but I do have a story that's linked to that. And during fellowship, I took care of a very premature Bosnian baby.
Mm-hmm.
And
again, this is down in Worcester where you did your
down
fellowship.
in Worcester at UMass, correct. So the story is actually quite interesting. The parents lived in Bosnia in a very small village, became pregnant, and at 25 weeks, the mother broke her water,
okay,
which typically is a harbinger for labor and delivery to come shortly thereafter,
right,
typically within a week or 10 days or sooner. So they went to their local doctor, mm-hmm, who told them that we're sorry, there's not much we can do for you. Most likely your baby is not going to survive. So that's sort of their final position.
That's tough.
Yeah. The family was not satisfied with that response, mm-hmm, from their physician and realized that they had family members in Worcester, Massachusetts who had recently immigrated to the States. So they got on board a plane. Here's a woman at 25 weeks who had already broken her water, so was at risk to deliver really at any time.
She must have been terribly worried.
Yes. She and her husband traveled to the States, flew to Boston, and then took a taxi to UMass Memorial in Worcester, where their family met them. And I met them shortly thereafter, did a consultation, told them that we would be able to support the baby in any way we could, and we would be there to help them for the delivery. The baby was born 6 days later, and survived, and actually is doing well.
That's great.
Yeah.
That's great. Well, Dr. Ryzewski, thank you so much for sharing that story. That's a great story. So when you and I were discussing this, and you touched on it a minute ago when you were explaining your passion and why you got into this specialty, one of the overarching themes that I got out of our talk, and correct me if I'm wrong, please, was that the majority of premature babies, the issue is the respiratory system. There are other complicating factors that can come into play, and I'd like you to discuss those, but primarily it's the development of the lungs. Could you talk about that?
Certainly.
Why it happens,
Sure.
and what you see? So
it all begins with the physiology of the fetus when the fetus is growing inside of the mom. The fetus and the growing infant are connected to the mom via the umbilical cord, and the umbilical cord is connected to the mom via the placenta. All of the oxygen that the baby needs and uses, as well as nutrients and vitamins, are passed to the baby through the maternal placenta, through the umbilical cord to the baby. So unlike babies and adults who obtain their oxygen from the atmosphere and exchange it into their blood through the respiratory system, babies do not perform that function. So lungs, for all intents and purposes, are not functioning as they would on the outside life. So from an evolution standpoint, lungs take a very long time to develop during gestation and typically aren't mature until after 30 to 32 weeks.
So the whole body for a baby doesn't develop at the same time.
That's
it
true.
does it in stages, right?
Yes.
And so why, if the baby's not going to have any air, why should the lungs develop?
That's right. And so when babies are born, under, say, 32 weeks, somewhere in the 24 to 25 week gestation, their lungs are still growing and developing. And they still have a lot of developing to do. For example, if the baby is born at 25 weeks. Very interestingly, your lungs continue to develop and form the air sacs that perform gas exchange so you're able to get oxygen all the way out until children are in, say, kindergarten.
Really?
Age 5 to 6. So your lungs are developing well beyond the infant newborn period, into the toddler stage and even to school-age children.
Oh, wow. I didn't know that, Dr. Ryzewski. Wow. That's amazing. So therefore, regardless of the reason that the baby doesn't make it to term, again, defined as 37 plus weeks, chances are they're going to have some issue relative to their lungs. Not always, but chances are there's going to be some development that needs to occur.
And it certainly happens at higher percentages. It's relative to the gestational age. It certainly happens at higher percentages with babies who are born more premature than not. And the reason is because there's definitely issues with the lungs that are still developing. So there's basically anatomic limitations of what the lungs can do in an extremely premature baby.
So that leads us to sort of the next segment, if you will, or trying to flesh out your specialty of neonatology. And when we spoke, you mentioned that your role is really multi-system management, right? And so we've just talked about one system, the respiratory system. We didn't talk about how you manage that, but I'm sure we will. But why don't you share with our listeners what you mean by multi-system management?
Certainly. So as neonatologists, our role is really to manage all of the systems within the newborn. And that begins with the respiratory system, the cardiac circulatory system, as well as the gastrointestinal nutritional system, and various others. So when we have a infant in the NICU, when we go through and we manage their care on a daily basis, we go through each of their body systems one by one and develop a plan and a management plan for each of those systems. For example, the respiratory system. A baby who's extremely premature, who has insufficiency of the respiratory system, may require assistance with a ventilator or a breathing machine. So our management of that would be making sure the baby is on the appropriate settings of the ventilator and making sure that they're getting enough oxygen, and then each system would come thereafter. So our goal we are really generalists for the newborn baby. Much like a general pediatrician for your child or a general internist for an adult, he comes in, we do a full head-to-toe examination. And we manage all of the body systems.
So staying with the respiratory system, Dr. Ryzewski, you said that a baby could need a ventilator, which is a mechanical means of breathing for a baby, right? It doesn't have anything to do with beating the heart. It's just the lungs keeping oxygen or air in the lungs, right?
Correct.
What are some of the other step-down, if you will, treatments for getting those lungs to develop? Because not every baby needs a ventilator.
No. We like to say that insertion of a breathing tube into the airway in a baby that gets mechanical ventilation is probably one of the most invasive respiratory management strategies that we have. There are, as you said, step-down measures. Some babies just require like a nasal cannula with two prongs going into the nostrils, providing a little pressure to keep the lungs inflated. And a step down even further from that would be just flow, going through, oxygen flow going through to provide the babies a little extra oxygen to keep.
Meaning it'd be almost what I would call an isolette with a higher level of oxygen in it. Is that what you mean?
There's something that's called an oxygen hood, which can just provide an oxygenated atmosphere around the baby's airway to provide a little extra oxygen. That's the least invasive mechanism that we have.
So a question just popped into my head, and I promise I'm not going to stump you.
No problem.
And I know I won't. But when I think of a ventilator and I think of any kind of mechanical assistance in breathing, I think it's got to be very, very uncomfortable for anybody, including a newborn. What do you do to keep the infant comfortable? And do you have to sedate the baby at all, or is the baby usually pretty just complacent?
Sure, and that's actually a field that's evolved over time. It was felt in the early days of neonatology that, they're babies, they're very premature, they don't feel pain, we're not going to provide pain medication. And then the pendulum swung very dramatically to the other side, and a lot of neonatal intensive care units were using lots of pain medication and sedatives and actually even paralyzing agents for babies that were on breathing support. That has fallen out of favor. So now we sort of find ourselves in more of a middle ground in terms of pain management for babies. In other words, providing them intermittent pain management for pain or agitation, but not providing too much, because what we have found is that babies benefit actually from having their own respiratory drive and breathing on their own. And sometimes too much pain medication and certainly paralyzing agents actually take away from the respiratory drive and the baby's ability to breathe on their own. So we want to assist the baby and support the baby, but we also want to support the babies as they have their own internal drive to breathe.
So, of course, every baby is going to be different, and depending on when the baby is delivered, at what gestational age they're delivered at is going to probably dictate this. But what can somebody expect for a length of time on mechanical ventilation?
Sure, and that's definitely dependent on what's going on with the baby.
Sure.
We've certainly seen babies who have spent anywhere from a few hours on a ventilator. In other words, they're able to wean off the breathing machine very quickly. Because of either advanced gestational age or because of lungs that are more mature, to the opposite end of the spectrum for babies who are born extremely premature, say 24, 25 weeks.
That's extreme.
That's extremely premature, correct. And those are babies are usually called extremely low birth weight as well. These babies can have significantly underdeveloped lungs, and these babies can be on a breathing machine for weeks or months at a time.
And there are obviously some complications associated with that you have to manage. You have to make sure that they don't get an infection, things like that.
Certainly. What we also have learned over time is that, oxygen is a good thing, but even too much of a good thing can be bad. Oxygen, like other medications, has side effects, and even ventilators have side effects. So over time, we've learned to be better about fine-tuning ventilators and not providing too much support.
Great. So, Dr. Ryzewski, we're bumping up against break, and a little bit later in the show, I want to talk about the measures that you take, in particular at the Elliot program, to comfort the family and to allow mom to bond with baby. Because when you mention that a baby's on a ventilator for weeks at a time, right, that just brings up sort of the natural process. But we're going to cut away now. And I'm going to invite the listeners once again to call in with any questions they might have about neonatology. 603-669-1370 is the number. Again, 603-669-1370. We'll be right back.
We didn't start with the idea of a new facility, but as ideas evolved, they led to the Elliot at River's Edge.
Elliot Orthopedic Surgical Specialists is a group of highly skilled doctors.
We provide comprehensive diagnostic testing for sports injuries and other mishaps.
Whether we repair, replace, or reconstruct hips, shoulders, hands, or knees,
our doctors will diagnose and begin treatment plans right away.
I'm Dr. Mary Lee Soul.
I'm Dr. Jonathan Mack.
I'm Dr. Paul Scavetta.
I'm Dr. Martin Ross.
I'm Dr. Rob Parisian. Our complete orthopedic team is ready to treat you.
The Elliot at River's Edge is now home to the most advanced ambulatory health care in New Hampshire. It's also comforting to know that Elliot Surgical Specialists and the nationally acclaimed Elliot One Day Surgery Center are at the Elliot at River's Edge off Queen City Avenue. Elliot at River's Edge. We're ready to get you back to your active life. For more information, go to ElliotRiversEdge.com.
At Catholic Medical Center, we believe that excellence in healthcare and personal respect for our patients go hand in hand. From our primary care and laboratory services, the Mom's Place, to our minimally invasive robotic surgery, CMC meets your every healthcare need. Our expert specialists and caring medical staff are dedicated to being your lifelong partners in good health. CMC, leading the way with heart. Find out more at CatholicMedicalCenter.org.
When you have digestive problems, you need to turn to a gastroenterologist who listens and responds, an experienced doctor who knows the field and can effectively diagnose and treat your needs. New Hampshire Gastroenterology in Bedford is now opening a new office in Nashua. You'll receive the same superior and compassionate care from their dedicated team of trained gastroenterology professionals who give you the individualized care that you deserve. Call New Hampshire Gastroenterology today at 625-5744 or visit nhgastro.com for their 2 locations in Bedford or Nashua. You're listening to On Call with Minuteman Health. This show is informational and not intended to be used as a way to diagnose or treat medical conditions or to replace an appointment with your medical provider. For immediate and medical attention, consult your primary care physician, call 911, or seek care at the nearest emergency department at a local hospital. And now back to On Call with Minuteman Health.
Good morning, folks, and welcome back to On Call with Minuteman Health. I'm your host, Scott Colby, and in the studio with me this morning is Dr. Matt Ryzewski, who is a neonatologist at the Elliot Hospital in Manchester. Once again, Dr. Ryzewski, it's a pleasure to have you here.
Good morning, Scott. Thanks again.
I'd like to invite the listeners to call in. 603-669-1370 is the number if you have any questions about neonatology. So, Dr. Ryzewski, when we went on break, you were beginning to discuss the fact that, and we were well into it, that you manage the multi-system failure, if you will, or conditions, that are sometimes present within a premature baby. But before we get into, so we started with the respiratory system, and before we get into the cardiac and the gastrointestinal system, I wanted to give you an opportunity to help our listeners better understand the reach of the program. When you were describing Elliot as the level 3 in the state, and really a regional referral center is what you implied in your statement. I think I moved us too quickly away from that. I'd like to talk about your collaboration with other programs.
Certainly. So we work with multiple community hospitals here in the southern and middle part of New Hampshire because, truthfully, babies are born at other places than just the level 3 referral center.
Sure.
So actually, if you look at calendar year 2015, the Elliot had approximately 400 admissions to the neonatal intensive care unit.
Wow.
Of those admissions, 100 were babies who were transported in from other hospitals. So 25% of our census for 2015 was from outborn. Those are called outborn infants, babies born out in the community. So with respect to that, we work very closely with these community hospitals. And one of our initiatives beginning at the end of 2015 was developing and really fine-tuning a comprehensive outreach program with these community hospitals. Mm-hmm. In the past, we had done what are called case reviews. Mm-hmm. In other words, they send us babies. We have our transport team, which goes and picks them up. And then later on, at some time, we go back and we discuss with them, oh, this is what happened to the baby that you sent to us. And that's very helpful for them because they can learn management strategies. And also, it's good follow-up to see what happened with the baby. We're trying to take it a step further, and what we're doing now is, instead of just reviewing the cases that we've had, performing more of an educational role and more of a hands-on educational role with the community hospitals. Mm-hmm. We see it as our privilege and responsibility to be partners with these community hospitals and educate them and help elevate the level of care that they're providing for the outborn infant so that they can better stabilize those babies.
So if I could connect the dots here, and please steer me in a different direction. I was going to ask you, are most premature babies premature by surprise, or do we know that they're going to be delivered prematurely? And it sounds like it's somewhere in between, especially out in the communities, and maybe what you're trying to accomplish is a better way to manage the care of the mom before the baby is born to bring her as close to full term as possible.
It's really a two-pronged approach. So certainly we work very closely with our OB and maternal fetal medicine. Those are the specialists in high-risk pregnancies.
Yep.
to help take better care of the moms, in that moms who are at risk to deliver prematurely, working on getting them transported to the level 3 referral center to avoid an unexpected delivery out in the community. Certainly, though, some babies are born by surprise prematurely.
Okay.
For example, a woman at 25 weeks who's having an otherwise innocuous pregnancy with no red flags or risk factors, all of a sudden can go into preterm labor. And sometimes there is no explanation for it.
Okay.
That would be a surprise.
Sure.
There are other situations, however, where we have some clues that this is an at-risk pregnancy. For example, someone who breaks their water, for example, at 24, 25 weeks. Delivery usually happens shortly thereafter, within a week or so, in most cases.
Yeah. But even that, Dr. Ryzewski, if I may, that's almost a surprise too, right? Because
certainly.
Because you wouldn't expect the water to break at that stage.
Certainly. There are other clues, though, in terms of if the baby is having intolerance. For example, there's some issues with the baby's heart rate. That can sometimes be a red flag that we may have to deliver this baby prematurely. And also, too, if there's more than one baby in the womb. For example, twins, triplets, etc. Those babies typically, historically, don't always make it to full term and deliver prematurely. And for example, triplets, a great majority of triplets deliver sometime around in the 32 to 34 week range.
I didn't realize that. Okay.
Yeah. So there are sometimes clues that we have that, these babies may deliver prematurely.
So part of the program and part of what you're offering the broader New Hampshire community is that clinical partnership with the community hospitals to help them identify moms who may be at risk, but also debrief on the cases you receive to see what, if anything, could have been done better.
Exactly. We do retrospective analysis of cases to talk about how things may be managed differently, and also too, if a baby like that comes through your doors again, here's how you might handle it. And also too, making providers in the community more comfortable with things like resuscitation of the neonate, because extensive newborn resuscitation is what we call a low frequency, high risk event. It doesn't happen all that often, but it's a very critical time for babies.
Resuscitation, getting them to breathe.
We're getting them to breathe, establishing a heartbeat and the circulatory system, which sometimes requires, as we've mentioned, respiratory support, insertion of a breathing tube, but also sometimes administering medications to jumpstart the circulatory system.
Great. Well, thank you for that. I think, again, even though it was a little bit of a detour from the sequence that we were going in, I think it's important for the listeners to understand the clinical collaboration that occurs throughout the state that you help initiate. So, Dr. Ryzewski, back to the multi-system approach. Walk us through, if you could, some of the care that you might render, some of the things you might monitor for the cardiac system, the circulatory system.
Sure. So the cardiac system, unlike the lungs, develops very, very early when the baby is growing. And typically the heart is beating and the circulatory system is functional and basically complete and just needs to grow by about 8 weeks gestation. Wow. So it's actually very early on in development. We manage, after babies are born, we certainly manage things like their blood pressure. Sometimes babies have lower blood pressures at birth. We also manage things like structural defects of the heart. For example, again, the transition from the fetus to the newborn deals with a very delicate balance of pressures and flows throughout the newborn heart, and certain channels are supposed to stay open and certain channels are supposed to close. And sometimes what we do with our blood vessels that actually remain open longer than they should. That would be something, the clinical term for that is something called a patent ductus arteriosus. And the management of that is very controversial in our field, but that is one of the circulatory system issues that we manage very frequently in extremely premature babies.
And how is that managed?
It's managed
medication?
It can be managed in multiple ways. Certainly it can be managed by not providing too much blood volume or too much circulating volume to the infant. It can also be managed medically. For babies who are having very significant clinical setback from a PDA is the acronym. those babies sometimes require cardiothoracic surgery to actually close the duct.
And it would seem that the frequency of cardiothoracic surgery, open heart surgery for an infant, is so low in this state. I wouldn't think you would do those. That you would need to ship a baby out for open heart surgery.
But yes. So our region here in southern New Hampshire, our babies go to Boston Children's Hospital for cardiac surgery.
Right.
And you're right, the incidence of that is very, very low.
Right. So you want a center that specializes, that sees enough of these so that they become
right, and has a deep staff of cardiothoracic surgeons.
Sure. Okay. So Dr. Ryzewski, GI system.
Sure.
What kind of issues do you see with the digestive system of a baby?
Sure. So babies that are born premature, say less than 32, 34 weeks, typically don't have the neurologic ability to be able to feed.
Okay.
Because, breastfeeding, bottle feeding requires coordination with breathing as well as different neurologic reflexes and neurologic functions to be able to perform that function successfully. And preterm babies, when they're in the maternal womb, aren't feeding.
Right.
So their GI system is relatively naive to
it's a good term. Yeah.
Exactly. And also, too, it's naive to things like breast milk and formula, et cetera. So our goal is, and this is also part of our field that has evolved very rapidly over time, is understanding that the nutrition of the premature baby is extremely important for neurodevelopmental outcomes as well as growth. So our job is actually providing maximal nutrition to the preterm infant, as well as we know the benefits of starting feedings early in babies.
Okay.
So we actually provide feedings through a feeding tube for the early days of life for babies who are extremely premature.
Okay.
So our management comes into making sure the babies are getting appropriate nutrition and also tolerating that nutrition and monitoring their growth. So much of what we do is feeding and growing. Providing good nutrition and watching babies grow.
And Dr. Ryzewski, at what age will you then go from a feeding tube to introduce the baby to either breastfeeding or bottle feeding?
Yeah, and that's a little bit of a gray zone.
Because it depends on the baby, I understand.
Certainly, but sometimes babies will start to show cues. For example, they will start to show they'll start to lick their lips or make almost like a sucking motion with their lips, typically sometime around 33, 34 weeks, depending on the baby. And we'll actually start breast or bottle feeding babies or some combination thereof around that time in a baby who's otherwise well.
So, Dr. Ryzewski, there's a couple other conditions that I'd like to talk about and then move over maybe after break to talk about the family and the support.
Sure.
But you mentioned that sometimes a baby is born with an illness too, right?
Mm-hmm.
Maybe a physical ailment or condition, or maybe an infection.
Mm-hmm. So we know that the immune system of newborns is relatively immature compared with older children, adults, etc. So they are more susceptible to bacterial, viral, fungal infections, for example. So part of our job as managing newborn babies is being on surveillance for infection and also providing appropriate antimicrobial medications to cover them for potential infections. So we're always on the lookout for things like sepsis. That's also one of the more common diagnoses that we see.
Okay, and sepsis is an infection of the blood?
Correct. Sepsis would be a bacterial or a viral or fungal infection that occurs sometime in the newborn period.
So again, your specialty doesn't focus on one specific area of the human body. You are really looking at multi-system approach to monitoring and caring for your patient.
It's a global approach.
Great. Well, Dr. Ryzewski, we're actually bumping up against break, so we're going to cut away. When we come back, I want to bring it back to the family a little bit and the human interaction and what you do to support that. Dr. Matt Ryzewski, neonatologist at Elliot Hospital, is here this morning talking about his specialty. 603-669-1370 is the number. Again, 603-669-1370. We'll be right back.
People are finally doing something about the rising cost of their health insurance. They're switching to Minuteman Health. Minuteman Health could save you $1,000 to $5,100 a year on your premiums. Enroll at MinutemanHealth.org. Savings based on healthcare.gov comparison of the lowest cost 2016 silver plans for all carriers in 03215 for a family of 4, 2 adults age 40 and 2 children under 21, all non-smokers. Provider networks, benefits, and cost-sharing amounts vary.
At Catholic Medical Center, we believe that excellence in healthcare and personal respect for our patients go hand in hand. From our primary care and laboratory services, the Mom's Place, to our minimally invasive robotic surgery, CMC meets your every healthcare need. Our expert specialists and caring medical staff are dedicated to being your lifelong partners in good health. CMC, leading the way with heart. Find out more at CatholicMedicalCenter.org.
We didn't start with the idea of a new facility, but as ideas evolved, they led to the Elliot at River's Edge.
I'm Dr. Joe Guanascia. There was a lot of talk about this being the right time for urgent care.
It's a perfect choice to treat illnesses, accidents, or injuries, or when your doctor's office is closed. I'm Dr. Kevin Rankins.
No one wants to take up time in an emergency room when others might need that time for life-threatening injuries.
Urgent care quickly gets you to a board-certified emergency doctor.
These days, making urgent care easily available and accessible means health care is less expensive for all of us.
Urgent care is a great option when you don't need an emergency room visit. I'm Joanne Waska-Cormier, LPN.
Urgent care at the Elliot at River's Edge. It's faster than an emergency room visit.
You're going to love our care.
Urgent care is open from 7 a.m. to 10 p.m. every day. No appointments necessary. Located right off Queen City Avenue at the Elliot at River's Edge. For more information, go to ElliotRiversEdge.com.
You're listening to On Call with Minuteman Health. This show is informational and not intended to be used as a way to diagnose or treat medical conditions or to replace an appointment with your medical provider. For immediate and medical attention, consult your primary care physician, call 911, or seek care at the nearest emergency department at a local hospital. And now back to On Call with Minuteman Health.
Good morning, folks, and welcome back to On Call with Minuteman Health. I'm your host, Scott Colby. And in the studio with me this morning is Dr. Matt Ryzewski, neonatologist at Elliot Hospital here in Manchester, and we are discussing the specialty of neonatology. Dr. Ryzewski, thank you again for joining me, and this is the last segment.
It's going by quick.
It does.
You're welcome, though.
It always does. So great. You've done a really nice job articulating the journey that a newborn can take and the multi-system approach that you take to care, and thank you for that. Part of what happens, though, in this 26-bed unit at the Elliot Hospital is that people are sort of giving up for a period of time the ability to have some normalcy with their child, to bond with their child, and it's got to take an incredible toll on the nuclear family, on the grandparents, on anybody who's significant in that child's life. And I was wondering if we could just move over for several minutes and talk about what it is that your program does to help support that transition from the uterus to life and the bonding experience.
It's an excellent question, and there's really multiple ways that we move towards fixing that issue.
Sure.
Certainly what we try to do, I'll start by saying that we do what's called family-centered care and family-centered rounds, for example. So rounds are when doctors and the multidisciplinary team, which includes nurses, nurse practitioners, pharmacy, nutrition, social work, case management, etc., because it really is a team approach.
Yep.
When we make our rounds on the baby and we review the baby's body systems and talk about how we're going to manage and move forward for the next day, we include the parents in those discussions as often as they can. And typically that hasn't always been done. Typically units would be closed during rounds, no visitation, etc., during medical team rounding. And what we've learned over time is that families really appreciate hearing the data, hearing the medical information, and actually in some way being part of the decision-making process.
And do all of them participate in this?
As often as they can.
Okay.
Most families are there on a daily basis.
Right.
But we understand, too, that people have to go back to work. People have other children, other obligations. So they can't always participate in rounds. But as often as they can be there, our goal is to include them in that process and make them, in a way, partners in the decision-making. Because sometimes they can read cues from their baby because we're not at the bedside all the time.
Sure. Sure.
So we get significant input from our neonatal nurses, for example, who are at the bedside 24/7, but also parents who know their babies very well, especially over time. So that's one way that we include the families in this experience to help ease that transition.
And it helps give them a little bit of control, I would think.
Yes, because that's also another issue, is sort of giving up that control, because it's very different from being the sole caregiver or part of a caregiving team in your own personal home. Other things that we do are initiating things like kangaroo care for babies, because we know that the bonding between not just mother and baby, but father and baby is very important, and doing what's called skin-to-skin time for infants.
Is that what you mean by kangaroo care?
Kangaroo care, exactly. So, for example, placing the baby on the mom's chest or the father's chest, and just letting them have some holding time. And we can actually do this for babies who are, for all intents and purposes, stable, but that can also be babies who actually have a breathing tube in. It's a very delicate process, but once things are secure and the baby is tolerating it we allow moms and dads to hold their babies. For example, just the other day I was walking through the unit and we have a set of twins, and one twin was on the mom's chest, the other twin was on the dad's chest.
Cool.
So we've gotten away from, babies being inside, a plastic isolette, traditionally called incubators, and just sort of looking through and seeing your baby and not having any physical contact with them.
Several minutes ago, a few segments back, you had mentioned that a baby can be on a ventilator for weeks at a time, and that has got to be terribly painful for the family, and actually for the baby too, to not have that human contact, that skin-to-skin contact. But you're able to make accommodations to allow that to occur.
It's true, and we even start it as early as the delivery room. I've been involved in quality improvement projects during my training where our goal was to get the mom or the parent to at least touch the baby right after birth. Just so they have that experience of seeing the baby. The baby isn't rapidly whisked off to some remote part of the hospital and you don't see or touch your infant. Our goal, as always, is to have the parents see and possibly even hold their baby before they come and spend time with us.
And it seems to me, Dr. Ryzewski, that it would be very important for that to occur too, because if a baby's very premature, they're going to be super, super tiny too, right? And the mom and dad might not really know how to hold a really, really tiny baby.
That's true. So there's some technical difficulty with that, but there's also a little bit of a level of comfort issue with well. But that's all part of the educational piece. In that, our nurses and we have physical therapists, occupational therapists. So much of what we do is a team approach to the care of these babies, who help parents work through the process, get comfortable holding their babies, and benefit so much from that bonding experience.
Does the support go beyond just mom and dad? Does it typically include the extended family?
It can.
It can.
Certainly, also what we try to do outside of our daily rounds and just talking at the bedside informally with families and parents, we also have meetings. We hold family meetings periodically, specifically for babies who have significant illness and also babies who are with us over several weeks' time, because you can't always catch people. For example, people visit in the late evening when the team is not all together. I've held many family meetings with mothers, fathers, grandparents, aunts, uncles, etc. And it's so nice to see parents have a wide support network of their families to help them get through this, because it is a very emotional time. And so we try to be there for the whole family beyond just the parental unit.
And you have a pretty big unit, Dr. Ryzewski, and you have, I think you said you did 400 babies in the program last year. Do families support one another? Do you see that happening as well?
We do, and that's a very nice thing to see. Because some of we have private and semi-private rooms, so some babies and families are actually sharing a room with one other. And we also have, we developed specific spaces in our unit for family, as a family place. For example, we have a kitchen area, we have a lounge area for families to just be. so that they can, be present, but they don't have to necessarily be at the bedside 24/7. And we've seen families get together and talk and support each other through the process and congratulate one another when one baby is getting discharged. And, that's something that we have seen, because you grow close to people if you spend a very long period of time with them.
Right, and that shared experience. So that's great. And those are really important elements of the program that we may not think about. I want to move over and spend the last few minutes of the show talking about something that's a very serious topic, and none of us probably wants to hear about it, but I think we should address it. And you referred to the condition as neonatal abstinence syndrome, NAS. And essentially, that's for babies who are born to moms who have used substances, whether they be prescription drugs or illegal drugs, and that the baby can actually become addicted. And I want you to talk, if you could, Dr. Ryzewski, a little bit about what you have seen yourself, what you have heard in the program as far as the increase in the incidence of NAS, what you do to manage that, and some of the social barriers that get in the way.
Sure. So NAS is
a lot to do in 3 minutes.
Sure, no problem. I'll do my best. It's an issue that's certainly on the rise, and you mentioned before it is a healthcare epidemic that we deal with quite extensively in the newborn population. And our goal of management is really to keep babies comfortable. And we know that they're having a withdrawal syndrome. Moms who either use illicit substances or prescription medications, whether legally or illegally, the babies can become, as you said, accustomed to having that substance in their system, and then once they're separated from the mom, they can have a withdrawal syndrome.
Sure.
Our goal is to treat that medically, but also we use non-pharmacologic means of doing that by keeping the babies in very quiet spaces, very dark, dark spaces, low lighting, low stimulation, because we've learned that over time that helps heal babies and gets them through the withdrawal process. And many units throughout the country are utilizing different quality improvement measures to reduce the length of stay for babies with withdrawal in the unit. Because traditionally, when this first became an issue a decade or so ago or beyond, babies would have to be in the hospital for many weeks, 5, 6, 7 weeks, weaning off of different support medications to get them through the withdrawal. What we've learned over time is with the benefit of optimized both pharmacologic and non-pharmacologic means that we can get babies home sooner to their parents. And there are, of course, distinct social issues that go along with that.
Sure.
In terms of dealing with parents who have who lack the capability to care for the infant outside the hospital. We have very significant support and input from our social work team and case management team because there can sometimes be custody issues with these infants. So our goal then sometimes moves beyond the medical realm with making sure that these babies are safe for discharge and are also going home to a safe and healthy environment.
Right.
Because our goal as neonatal physicians is to take care of babies not just within our own walls, but also to make sure that they're doing well out in the community.
Right, and that the baby has a chance.
You bet.
So, Dr. Ryzewski, I hear the music in the background, so that tells me we're less than a minute out. It's been a great show, and I think if there's one takeaway from me on your specialty of neonatology, it's the tremendous advancements that have been made and the hope that you're able to give families.
That's a great way to encapsulate it, Scott.
Great. Well, Dr. Ryzewski, thank you once again for joining us this morning.
You're welcome.
Dr. Matt Ryzewski of the Elliot Hospital, neonatologist in the NICU, does great work. Folks, thanks for listening. You've been on call with Minuteman Health. Make it a great week.
WCID HD3.